Hello and welcome back, guys, to this wonderful, lovely evening. We'll be rapidly revising infectious diseases, and all of you must be aware that the exams are around the corner. So we are going on a rapid streak now, and we'll be frequenting the classes a bit more. So don't worry about that. Also, infectious disease is a quite a huge chapter to say that. Like as a chapter, it's not just a chapter; it's like a whole phenomenon in itself. So keep your eyes, ears, everything open, guys. Okay, like you need to have a grip, very tight grip on infectious diseases, because not only it occurs, the questions not only come directly from infectious diseases, but internal medicine as a whole has infectious diseases like rotating all over it, right, guys? So put on your thinking caps now, grab your cup of coffee. I will be waiting for your answers today, so please let me know your answers, whatever it is. Just write in the chat box. Nobody is here to judge you, all right? So let's make this interactive, and let me try and see how you are thinking. So if we can correct somewhere, that will be wonderful. If you're answering correctly, kudos to you guys. Okay, so let's just quickly get started. Okay, so here's the first question of the evening. So I'll give you exactly 30 seconds to read the question and answer it. Okay, so I'm still waiting for some answers. All right, so let's quickly go through the question now. The question reads, 19-year-old woman presenting with fever, rash and cough and tachycardia, tachypnea, florid erythematous rash on her face, trunk and arms, scattered whitish papular lesions on the buccal mucosa, full blood count, hemoglobin is normal, WBC looks pretty okay, and platelets are reduced. Now you can see that there is a slight reduction in the WBC count as well as in the platelet count, right? So they are slightly reduced over here, very slightly though, but yes, they are reduced. So which one of the following options do you think is the most likely the answer, guys? Come on. So we would go with measles over here as the right answer, and I'll quickly tell you why. Because in infectious diseases, more than the right answer, you need to be very thorough why the other answers are not the correct answer as well, right? So let's go through the question once again and we'll understand that. She has a florid, okay, it's completely everywhere, erythematous, rash, everywhere, but she has a whitish papular lesions on the buccal mucosa, right? So those of you watching live, I want you to tell me what is the name of the rash that the question stem is referring to over here. A whitish papular lesion on the buccal mucosa, which is characteristic. This is the characteristic statement, guys. Like you cannot go wrong when you read a whitish papular lesion on the buccal mucosa of a young patient. Okay, mind you, measles question will usually give you very young patients. They'll usually not occur in your exams in a patient, let's say 45 years of age, but the usual age would be around 14 to 25 years of age. Okay, patients are usually young, remember that. Now the WBC and the platelet count will be slightly reduced. They can be normal as well, but WBC count will definitely be slightly reduced. Okay, now let's go through what is given over here? The answer is here, the one that I was asking you, right? So as you can see, right. So a maculopapular rash is there, the classic feature, but the Koplik spots that we were mentioning about is the characteristic feature, right? And also the thing that will be mentioned in the question will be the face. The rash will definitely be on the face, as well as it will cover the ears. Okay, so it will definitely start from ears and it will cover on the face, right? And it will go downwards. Okay. Now, lymphadenopathy is something that will be followed with measles, but it might not necessarily be present in the first presentation. So measles, the first presentation that the patient is coming to you, lymphadenopathy might not be there. So how will you diagnose a case of measles in your MRCP part 1 exam? Number 1, Koplik spots. Okay. Koplik spots are a definite indicator that you are talking of measles. Okay. Second thing is fever with cough. Okay, but fever with cough is something that is present almost ubiquitously throughout the infectious diseases chapter, right? So then you have a maculopapular rash. Okay, an MP rash that starts from your behind the ears as well as face. These two should be covered, right? So these two are important. Okay. Now let's understand what are the other option over here. Meningococcemia, definitely that is not related to it anywhere. Okay. And rubella and parvovirus B19. Now the funny thing about parvovirus B19 is that it causes something known as slapped cheek syndrome or fifth disease, right? Please remember this, because sometimes in the question they might not write parvovirus B19, they'll write fifth disease. That is why you need to know these synonymous terms. Now here also you will find a prodrome of fever, headache, okay, but the characteristic rash of slapped cheek syndrome is looking like a slapped cheek syndrome, like no points for guessing that. So you have an erythematous rash over your cheeks, but sparing the nasolabial folds, right? As well as on the forehead, you never see it on the forehead, okay? So that is what your slap cheek syndrome looks like. Now, this is something that happens very early, like in almost pediatric age group, okay? So if they are talking of slap cheek syndrome, the pediatric age group will be the predominant factor. So this won't be there in your very adult patient, right? So again, the age group of the patient will be very young, right? Now guys, the idea here to teach you is to also understand how to link the things, right? So when we talk of nasolabial folds, what else comes to your mind when I'm talking of nasolabial fold, guys? Please tell me, what else do you think when we talk of a rash, erythematous rash on your cheeks sparing the nasolabial folds? Quickly type it in the comments box and let me know. Okay, so also secondary syphilis is not, it does not look like this, right? In fact, you have something known as condyloma latum, right? So that is the one that happens in secondary syphilis. Now your time starts again for the next question, and quickly go through the question and let me know the right answer. Sorry about that. Yeah. Okay. So the one question that it's talking about here is, it's talking about a 40-year-old South African woman. Okay, so the question over here is talking about a 40-year-old South African woman who presents with progressive confusion. Okay, guys, confusion is a symptom which is to be noted, and mild neck stiffness. All right. So whenever we talk of neck stiffness, guys, what do you think? What comes to your head, right? What runs through your meninges? What are we talking of? She's suffering from increasing headaches over the past 6 weeks, and she has now begun to suffer from worsening drowsiness. So this confusion is going towards obtundation, right? With neck stiffness. CT scan is showing basal meningeal enhancement. So pretty much it's a giveaway answer over here. Now the LP shows opening pressure of 200 mm of H2O, a turbid CSF with 500 leukocytes, out of which 90% are lymphocytes, a glucose concentration of 1, and negative results with India ink and ZN stain. Okay, so gram stain, India ink and ZN stains have failed to show any results. CSF protein is elevated with 1.05. Which one of the following options is the best treatment? Now, if you think of empirical treatment of meningitis, what is the answer, guys? The empirical treatment would be ceftriaxone. Correct. That is the answer. But now, are we talking of a bacterial disease over here or a viral disease over here? What does the picture tell you? So this is a lymphocyte predominant picture, right? And there is elevated leukocyte count as well. Okay. So, but on the very next sentence, they are saying negative results with gram stain, Indian stain, and ZN stain. So what happens here is sometimes it is not necessary that the organism will show up on the stain. Okay. For that, you need to take cultures. The idea of having the cultures in the first place is because your routine stains sometimes might not be able to give you the picture. What is the organism that is causing the defect? So definitely this is a case of meningitis that is going on. Agreed. Now, in fact, that's increasing now very rapidly because the patient's confusion is going on increasing with now leading to drowsiness. So in such scenarios, you have to look and you have to remember the table that we have given in our previous classes, how to differentiate between viral, bacterial, and tubercular meningitis. So this is a clear-cut case of tubercular meningitis, right? If it were just a bacterial meningitis, we would go with ceftriaxone. If it were to look like viral meningitis, we would go with acyclovir, right? But here we would go with option A, right? Now let's try and understand why are we talking of so many different drugs when we could simply deal with the 4 major drugs that happen to treat tuberculosis all over the world, right? These are the 4 drugs that treat tuberculosis, and you have the someone has mentioned Koplik spots. You are right, doctor. So Koplik spots is the correct answer for that one that we were talking of. Now, HRZE, that is your isoniazid, rifampicin, pyrazinamide, and ethambutol. This is your standard 4 drug that you will be using for tuberculosis. But in cases only and only, I will repeat it again, only and only in case of tubercular meningitis, okay, TBM. Right? Not even in the case of TB spine, because TB spine is a different entity in itself. TB meningitis is something which is life-threatening immediately. No doubt TB in itself is life-threatening disease, but urgently life-threatening is TB meningitis. And that is why we are being forced here to introduce corticosteroids. You can see here, we are using corticosteroids, although the evidence for this is a bit controversial, but we are not going into that. We are going into what the MRCP Part 1 exam needs you to answer. Okay, so please understand, for tuberculous meningitis, you will mark the option that talks not only of rifampicin, isoniazid, pyrazinamide, and ethambutol, but also corticosteroids. A second line drug such as streptomycin, kanamycin, these might be there, might not be there in your options, but please remember that corticosteroids in an option, if it is there and they are talking of TB meningitis, go ahead with that. Another thing we have mentioned in our previous classes, that whenever there is a patient of TB, there is some geographical association with it. But here in this particular question, this lady is South African in origin, which is contrary to what we spoke about, the patient being of Southeast Asian origin, right? So you can ask me that we have mentioned that the patient would be of Southeast Asian origin. So how come this lady from African origin is having TB? The idea of telling you that the TB patient presenting from Southeast Asian country is not to say that a patient presenting from UK cannot have tuberculosis, but to say that if a patient, if let's say this over here, it would be Southeast Asia. Okay. So in this particular context, the answer would swing towards TB unanimously only in your MRCP Part 1 exam. Whatever I'm talking over here is very relevant just to your exam. Your clinics, please, you can refer to the latest guidelines, right? But let's talk about exams here. So your exam, when it's referring to Southeast Asian population, it is a clear-cut indicator to move ahead with TB, right? Now, in the same question, they can look here, they have given the answer, one of the options as corticosteroids. This is just to understand whether you have understood that you have to just use corticosteroids or you all have to use the corticosteroids in addition to the 4 primary drugs. Also, the 4 primary drugs are HRZD, like I told you. You have to remember this, guys. The idea is very simple. For 2 months, you have to give quadruple therapy. That is this. The 4 drugs you have to give for 2 months, right? And for the next 4 months, you have to give isoniazid as well as rifampicin. Okay. There is not much role of pyrazinamide and ethambutol in the continuation phase. This is the initiation phase of the treatment. This is the continuation phase. So usually under normal circumstances and TB everywhere else, pulmonary TB, sometimes extrapulmonary TB mostly also, the treatment is usually of 6 months. Okay. But only and only in case of TBM, the treatment begins with the 4 drugs plus second line drug plus most importantly corticosteroids, and the treatment continues for 12 months. Okay. This is the only condition where you have to, because the concentration, look, the idea of giving corticosteroids in the first place is to reduce the inflammation. Okay. The patient is suffering from meningitis. Patient is deteriorating rapidly. You need to give corticosteroids to reduce the inflammation. But on the other hand, you need to deal with the infection as well. And the concentration, blood concentration of rifampicin and the other drugs, when they cross the blood-brain barrier, it's very less. Okay. That is why you need a prolonged exposure of 12 months to anti-tubercular drugs. Okay. That's how you will deal with it. All right. Let's go ahead and see what is the next question. Okay guys, so a 40-year-old man presents with swollen erythematous finger and right axillary tenderness 24 hours after being bitten by his pet dog. Now, he was careful to irrigate the cut with clean water afterwards and then dressed it with a clean dry dressing. Which one of the following options is the best treatment? So let me ask you a question first in the first place here. Would you actually treat this guy or not treat this guy? Because let's say he had a very minimal cut, okay, less than 1 centimeter. Would you want to treat this guy? Someone being bitten by a dog? Yes, you would want to treat this person. Why? Because there is a break in the epithelium. Whenever you have a break in the epithelium, there is a very high risk of infection. So subsequently, the patient is going to develop infection. So we will treat the person. Okay, very good. Now, what will you use? Which is the best option for treatment? Now, if you are well versed with MRCP examination patterns, you will understand that a pet dog bitten by a dog is a good indication for, the answer is without any doubt, it is co-amoxiclav. Okay, this is the answer. But the question again is, why co-amoxiclav? What it is that we are trying to target over here. So we are trying to target an organism called as Pasteurella multocida. Okay. So they can twist the question in this way, that the same patient presented with after being bitten by his dog, and the duty doctor, he prescribed the patient with comoxiclav. Which one of the following organisms are you trying to tackle with it? Right. So Pasteurella multocida is the answer. Okay. So that is how you will learn and understand the questions. Okay. Great. Now, Pasteurella is basically not a common organism in humans, but it is very common in dogs, like canine species. It is common in their saliva. Okay. So it is there, and that's how it gets transmitted. So it's not in humans, but yes, if there would be a human bite, then also you will start on comoxiclav, the patient. Okay. But I don't think they are going to ask that question. All right. Let's move ahead to the next question of the evening. Now I want you to answer this, and I'm waiting for your answer. Unless you answer this question, I'm not going ahead with the explanation. Please write question number 4 and then write your answer in the comment box. Okay, so you have answered, and let's go through the question. So 35-year-old woman returning from a journey from Gambia with a fever of 39 degrees Celsius, which is quite high, with rigors, vomiting and diarrhea. She took chloroquine and proguanil prophylaxis. Her oxygen saturations are 90% on room air. Pulse is 120. She is quite tachycardic, and BP is 80 upon 60. So the BP looks very low, right? So there's circulatory compromise as well. Now, this question is a very good example of how your questions are going to come and how you will deal with them. Like I said, geography is very important. As much as physicians, we hate geography, it is equally important to understand that it is not about just geography or something. It is about understanding the origin of the disease. Okay. So geography tells you what are the most prevalent diseases, right? The pages and the chapters of prevalence and incidences which you do not want to read are the ones that give you a hint to what infection you are dealing with. Now, Gambia is a definite marker for malaria. Okay. So I'm just going to tell you what are the markers in the question. And then she has a high fever, she has rigors and vomiting and diarrhea. If you forget diarrhea for a moment, fever, high fevers with rigors and vomiting, okay, these three are 100% markers towards malaria in a person who is returning from endemic region. So that's a double tick. Her oxygen sats are low, she's tachycardic, and there is circulatory compromise. So that is another tick for malaria. But the question here is, she has already taken the prophylaxis. So why are we thinking of malaria at all? If someone has taken the prophylaxis, they have taken it. So the idea is that most of the people, when they go on a trip, they are very excited about the trip and they want to do everything in their control to make that trip as beautiful as possible. So they pack in, let's say, chloroquine, proguanil, right? For the duration of the trip. Let's say the trip is of 1 week. So they'll pack in for 1 week. But the problem lies herein. Malaria prophylaxis needs to be taken 14 days after you have returned from your trip, because the Schizont phase and the other hypnozoid phase can persist specifically falciparum malaria, right? The most dangerous one. They can persist for about 14 days in your bloodstream, and then they can cause the infection. So usually when the patient has stopped taking the malaria prophylaxis, as soon as they come back to their original place, this is what happens. So you have to advise your patients to take the prophylaxis, chemoprophylaxis for malaria for 14 days, even after returning back to your home country. And that is where this question will trick you, right? So don't get tricked. The answer is still malaria. Very correct answer, guys. And I'm happy to see that you're answering, and you're answering correct. Okay. Now let's move ahead and see what is going on over here. So this patient is septic and she has developed ARDS, right? You can see the markers over here. Like I said, BP of 80/60 means circulatory collapse, right? So she's in shock. Okay. You have to deal with this patient in ICU. Okay. Now, travelers returning from West Africa or Africa in general, right? The East and West Africa have one more significance, and I want you to write that in the comment box. Don't worry, I'll be discussing the answers when we talk and meet in the next live session. But for now, I want you to keep running your brains. So tell me which other disease of infectious diseases chapter, let's not switch the chapter at least. So which other disease has this distribution of East and West Africa, right? And there is quite a lot of difference when the patient gets the infection from East or the West Africa. What is that disease, guys? Come on, tell me. Okay, so that is about it. You have to understand that prophylaxis has to be continued even after returning from the trip. Great. Now let's move on to the question number 5 for the evening. Please comment and tell me what is the right answer. Okay, so let's jump into the question and try and find out which is the correct answer. Sleeping sickness, as per the comment, is the right answer to what I had asked. You are right, doctor, in saying that trypanosomiasis is the one that varies, okay, from East to West Africa. Now let's see this one and try and find out what's happening over here. 23-year-old ex-IV drug user is seen in the OPD following a DVT 2 months ago, for which he is on warfarin therapy. Okay. So this question is a very good example of the approach that I have been trying to teach you guys, that instead of going from here, if you first look at the question stem, what exactly is the question that they are asking us, it will at least reduce your problem by half, because by looking at this question, it looks quite a huge amount of data has been put in over there for you to find out what is the right answer. But let's first read what is the question trying to ask us in the first place. Which one of the following tests is most likely to lead to the correct diagnosis with respect to his viral status? Okay, so basically we have to find out that out of these tests, which test is most likely to give us an answer, right, towards here. So now let's go through the question step. So ex-IV drug user with DVT on warfarin therapy. Great. This has nothing to do with viral load, right? That is how this is called red herring, right? They'll just put in things to confuse you, because the real patients come and present to us like that itself. So albumin looks normal. The blood test pretty much okay, except LDH quite increased, right? And bilirubin is high a little bit. INR is increased because the patient is already on warfarin therapy. Hemoglobin is fine. WBC is very, very high. and platelets are normal. You suggest that he should be screened for Hep B, C, and HIV. Very correct. This is how you deal with the patient in an OPD. Results come as follows. HIV 1 and 2 antibody tests negative. Okay. Hepatitis B core IgG is positive. Hepatitis B surface antigen is positive. Hepatitis B E antigen is negative. And hepatitis C IgG and PCR is negative. Okay, which one of the following tests now? So what we would want to do here is a hepatitis B DNA load, right? Because if you have someone with hepatitis B surface antigen positive, right? You have someone with hepatitis B core immune antibody positive. That means there is active infection going on, right? But the question says hepatitis B E antigen, envelope antigen is negative. So there is no active replication going on. The significance of E antigen is E antigen tells you whether there is active replication going on right now or not. So there is no active replication going on right now. That is what we know. But we need to understand what is the viral load so that we can understand the depth of the disease or the breadth of the disease here, which we can definitely see the disease affecting the patient because bilirubin LDH is quite high, right? So that's how you will deal with such things. Now, when we are talking of hepatitis B and we are talking of measles, we have spoken about measles. I want to share something with you, and that is there are certain vaccines that, right? There are vaccines that are permitted and some are contraindicated in HIV positive individuals, right? So what are the vaccines that are definitely contraindicated in HIV infected adults? So the first one is your influenza vaccine. Okay, the intranasal influenza vaccine is contraindicated. Then you have the oral polio vaccine that is also contraindicated. You have a BCG for tuberculosis that is also contraindicated. So these are definitely contraindicated. Now, if your CD4 counts are more than 200, there are certain vaccines that you can give to the patient, right? So these are your MMR. You can give your varicella vaccine, and you can also give your yellow fever vaccine. Why am I telling you this here is there is a lot of confusion around these three vaccines, guys. Okay. And there are certain vaccines that are very safe in all HIV positive individuals. Okay. There are certain vaccines that are safe. They include your hepatitis B, hepatitis A, H influenza or Haemophilus influenza B, Hib vaccine, the one which we call Hib vaccine, Japanese encephalitis, right? Then you have the MenC, that is the meningococcus vaccine, right? And you also have the other one that is ACWY1. This is the one. Then you also have pneumococcus vaccine. And then you have IPV, that is the parenteral form of the polio vaccine. You have rabies and you have tetanus. So these are the ones that are safe to use in HIV positive individuals, irrespective of their CD4 counts. Has nothing to do with their CD4 counts, right? So now you understand the whole conundrum is about these three vaccines, guys. But I have made your life simpler now. Please remember that these three vaccines are definitely contraindicated irrespective of anything. Please remember that these vaccines you can give instead of whatever is the status, right? But these three, MMR, varicella, and yellow fever vaccine, can only be given to an HIV positive individual if they have a CD4 count more than 200. So this solves one of your questions. Okay, please be very clear on this, because I have seen a lot of doubt about this, because in the questions sometimes you'll notice that the answer tells you it is yellow fever vaccine is the one that you have to give, but sometimes in the same question it will tell you the yellow fever vaccine is contraindicated. So that has been a point of confusion. So I've just solved your confusion, hopefully, right? So let's move on to the next question of the evening, guys, and come on, quickly answer. Okay, so we're talking of a 34-year-old coronary care nurse who has accidentally stabbed himself with a used needle from a patient infected with hepatitis C virus. Okay, now he attends the occupational health department and he's asking for advice from you. What is the most appropriate next step? Okay, so you are the occupational health doctor. So come on, doctor, tell me what would you do, because I'm still waiting for the answer. I've got one. I've got two answers. Okay, so correct. That is the right way to go about it. You would perform monthly hepatitis C RT-PCR/PCR testing. Now, what is happening over here is, guys, that in a hepatitis C patient, okay, there are basically two things that you can do. Okay, you can either first of all test the patient, or you could give treatment to the patient. Okay, now the treatment involves two things. First is immunoglobulins or interferons. For that matter, interferon is the one that you give in combination with ribavirin. Okay, so the only drug that you need to remember right now for your part 1 examination is hepatitis C, ribavirin, right? Interferon you should remember, of course, but ribavirin is the one that you should remember. But would you give ribavirin to a patient or not? So look over here. Definitely you would give, but only when the hepatitis C test comes back positive, right? Also, antibody takes time to develop, but RT-PCR testing is the first one to give you the presence of the viral load, right? The virus is there, right? So that is why this is the first one to detect that. And how often would you do that? Every month. Okay, now there are other things that need to be spoken about over here. There are two types of people, especially with this kind of scenario. Okay, there are people who respond to vaccine, okay, and there are people who do not respond to vaccine, right? So in this circumstance, you first have to understand that in this particular case, you don't have to worry about, in this question, that whether the patient is responding or not responding to vaccine. You don't have to worry. Okay, but in other scenarios, specifically related to hepatitis B, there are people who respond to vaccine as well as don't respond to vaccine. Okay, so if they are mentioning something like this, if the patient is responsive to vaccine, the first thing that you will do is to give a booster dose. Okay, if the patient is not responsive to a vaccine, then you will go with immunoglobulins or interferon, as the case might be. We're talking of hepatitis B, then immunoglobulins, hepatitis C, then interferon, correct? Now let's go ahead and see what is happening over here. So we are waiting basically for the seroconversion to happen, and let's see whether it happens or not. When it happens, in that case only we will start the treatment with ribavirin and interferon. For how long? 6 months at least. Okay, basically you again test the patient for viral load and you see whether the clearance has happened or not, and then you stop the treatment. But this is how you have to go about it. All right, let's move ahead to question number 7 of the evening, guys. Let's see what is the right answer here. Please tell me in the comments box. Okay, I'm still waiting for your answer, guys. The one which does not look familiar is the answer here. So that's the hint. Okay, let's try and understand what's happening over here. When inserting a central line, a medical FY2 trainee injures herself with suture needle that has been used to stitch a patient with HIV infection. So they are asking what is the injury sufficient to draw blood. Okay, now if this wouldn't have happened, then it would be something else. Patient is 45 years of age. She has been infected with HIV for 11 years. Okay. He has been compliant with therapy for several years and has recently changed his tablets because of alterations in his appearance. Okay. His last CD4 known count was 350. The medical trainee is offered post-exposure prophylaxis. Which regimen should she take? Again, like I mentioned you, if you would have read this sentence, it would save you a lot of time. The only thing that the question wants to seek here is what is the regimen of post exposure prophylaxis for HIV? Okay. But if you look at the question, there is a lot of information going on over here, right? So that is what in the exam, this will take up your time. Okay. So if you understand what it is that what I want you to understand is that instead of thinking that I am asking you not to read the stem, think of it this way. If you are better prepared to handle the question, what is the harm, right? So first of all, understand what it is that the question wants to know from you. It is not asking you whether the patient has been infected or not infected. What is the CD4 count? What does a CD4 count of 350 cells mean? Because when you go on reading the question from here, there are a lot of thoughts, like multiple millions of thoughts running, racing through your head, right? Almost 1,000 thoughts are racing through your head, right? You're sifting through so many answers in your head. So don't do all that. Just read the last question first. Look, have a gross look at the options, that this is what I want to find out from there. And you will understand that the question is simply asking for post-exposure prophylaxis for HIV. So the latest guideline says that tenofovir plus emtricitabine plus raltegravir is the one that you will give for post-exposure prophylaxis. Okay. Also, you will give this for how many days? At least 1 month or 28 days or 4 weeks, right? 4 weeks is the standard initial phase of treatment. After that, you will reassess the patient, whether the person who got infected, that trainee, she has developed any symptoms, she has seroconversion or not, because 28 days is quite a window period that in which seroconversion can be noted. Okay. So the latest guidelines say tenofovir plus emtricitabine plus raltegravir is the one for post-exposure prophylaxis. Great. Now let's go ahead and try and solve some more questions. Come on guys, tell me what's going on here. I expect you to solve this one, because personally I've spoken a lot about this in the other videos if you have seen. Okay. So you are called to review a 54-year-old man who is an inpatient on the infectious disease ward and has become acutely unwell. On examination, he is tachycardic, flushed, temperature of 38.3. He tells you that he received his first dose of antibiotic treatment a few hours ago. You suspect that this may be a Jarisch-Hersheimer reaction. Okay. Which one of the following conditions is most likely to be complicated by this reaction? Okay, so we are talking and thinking about Jarisch-Hersheimer reaction. So any spirochete over here? Can you spot any spirochetes? Yes, the answer is Lyme disease. Okay, so the correct answer for this one is Lyme disease, right? Caused by Borrelia. Borrelia is the one, and this is the spirochete infection. Like I said, the JH reaction is classically seen in syphilis. Okay, so if the question would be of syphilis, it is even more indicative of JH reaction going on. Okay, also to understand is this will usually present initially very quickly. Okay, like you give the first dose of antibiotics and a lot of bacteria will, as I'm so sorry, a lot of spirochetes will die. Okay, so the killing of the spirochetes, they produce and release toxins. It is this toxin release that cause the JH reaction. Okay, now what you can do here is you can first of all hydrate the patient and then watch. You can give antipyretics also and watch. Okay, but that's about the treatment part. For part 1 examination, what you need to understand is the symptoms follow the first dose of antibiotics, and within 24 hours, the patient presents with a sepsis-like picture. Okay, and slight hypotension. Now, why is it happening? Because of the toxin release due to a lot of spirochetes dying immediately after the administration of first dose of antibiotics. Most commonly seen in syphilis, caused by what? Treponema, right? Treponema pallidum. Also seen in other spirochetal infection like Lyme disease. Okay, great. Now let's go ahead and see what else is there. Okay, this looks a big one, so I'll give you 10 more seconds to answer that. Okay, so Dr. Naresh has answered it very correctly and very aptly. Yes, that is what is happening over there. So please go ahead and have a quiet look at question number 9 and okay, I'm still waiting for some answers from your end. Can't see any answer yet. Looks like a very classic infectious diseases question to me. The questions in infectious diseases can look very complicated. They can have very similar presenting features to each one of that. But what you need to do in your head is define 1, 2, or 3, maximum 3, but minimum 1, a very disease identifying feature. Okay, there are certain things which when you see, you cannot miss the diagnosis. Do not sway with your diagnosis here and there. Think what it is that is your one definite marker for that particular disease, and if it is that is present, that is a good indicator that the answer is the same that you're thinking of. If that's not present, then maybe you can think of some other things, but there should be at least one or two markers in your head which when you see, you should start thinking of that particular disease immediately without wasting any more time. Okay, so we have a 24-year-old master's student presenting to ED. Now, when we read this question stem over here, which one of the following is the most likely diagnosis? So we are trumped. We cannot do anything but to go back and read the whole thing from the beginning, right? So this will happen more often than not, but in certain cases, it will save your time. Okay. Now, young patient presenting with history of worsening headache, okay, muscle pain and fever. Usually he keeps well and no past medical history, playing lacrosse and rowing regularly for his college. Examination, he looks unwell, jaundiced, marked conjunctivitis, temperature is high, tachycardic, blood pressure of 110/60. He has some degree of neck stiffness and appears to be slightly photophobic, with scattered crackles throughout both lung fields on auscultation and diffusely tender abdomen. Okay, so he has fever, he has tachycardia, his BP looks shaky to me. He has neck stiffness, he has photophobia, he has lung involvement by scattered crackles, and abdomen is tender. Okay, so there is multi-system involvement over here. Okay, let's go ahead and see. The hemoglobin count is low, the WBC count is high, platelet is quite low, sodium is okay, potassium is slightly elevated, urea is quite elevated, creatinine is double the upper limit of normal, even more than that, ALT is slightly elevated, and bilirubin is quite heavily elevated because you could see that the patient is jaundiced. That means that the bilirubin levels are quite high. So what is the most likely diagnosis? If I had to tell this question in one word, what is that one word? The word is rowing. So this is a water sport, guys, right? And whenever they are talking of water sport, they want you to think of leptospirosis, no doubt on that. Whether this be a person who works frequently with sewers, wastewater handling, right? Where there could be a mixture of rat urine or some other form of water sports, someone who has been to a very old lake recently, swimming episode recently, right? So involvement of water should hint you towards leptospirosis, not only as a diagnosis, but involve multi-system involvement, okay, with kidney involvement. Look over here. Patient is in AKI at least, because they are saying that he has good health. So there's no doubt of CKD here. So this patient is in AKI. So you have lung involvement, you have kidney involvement, you have cardiovascular system involvement, right? You have liver involvement. This is leptospirosis, no doubt about that. Or Weil's disease, as they say. Why you should know that leptospirosis is also known as Weil's disease? Because in the options, they might give only Weil's disease sometimes. Okay. So usually rat urine is the one, like I was telling you, is the one to contaminate water and spread it through. Water is the mode of transmission. Okay. Conjunctivitis is one very important symptom again. Okay. But leptospirosis has a very, very, very multi-system involvement with pulmonary hemorrhage, renal and liver failure. Meningitis was also present. Neck stiffness was there. Photophobia was also there. Okay. You could also argue that this could be meningococcal meningitis, right? But the thing is, you could also have a rash. Then meningococcal meningitis will have a rash, faint maculopapular rash. Okay. Also, the neck stiffness and the meningitic signs are there definitely, but the patient's consciousness is not being mentioned over here. Okay. So the patient is having some meningitic signs, but it is not a predominantly meningitic picture over here. Okay. Like it was there in the previous question that we were discussing, right? The patient's consciousness level were going down. He was going towards obtundation, drowsiness, confusion, right? So that is a very classic meningitic picture. Very quickly, rapidly deteriorating patient is a meningitic patient. That is why you need to act very quickly and empirically. I told you what are the options that you will treat with empirical treatment. Okay. So that's about leptospirosis. Okay. Water sports, leptospirosis. Remember that. Okay. When I say remember that, don't think that if there is water over there, it has to be leptospirosis. But what I'm trying to say is, when you see contact with water or dirty water, exactly for that matter, leptospirosis should be high on your differentials, right? All right. Let's move ahead and look at the 10th question of the evening. So I'm still waiting for the answer, guys. Okay, so we have one answer. I want some more people to answer it. Okay, we have Dr. Naresh seconding Dr. Tayab's answer. D, urine antigen, urinary antigen test. This is what you guys are saying. So let me mark it straight away without even looking at the question for you, because I have full confidence in you guys. How much do you have confidence in yourself, guys? Right? So a 40-year-old businessman is admitted with a 5-day history of fevers, cough, and diarrhea. Great. 1 week after returning from a business trip to Rome. Okay, beautiful place it is. So he's a smoker but has no past medical history and is taking no regular medication. Saves a lot of time and effort. On examination, he is pyraxial, okay, a little bit, with the heart rate of 95, not tachycardic. BP looks pretty okay. The standard observation in most of the medical records is 120/80, right? You never find it in a real patient. And O2 sats of 93% on room air. So first thing that we have is a fever, cough, diarrhea, and a O2 sat of 93% on room air. He has bibasal crackles on chest auscultation. Good. So he has a scattered V's. Very good. And an unremarkable abdominal exam. Great. The blood tests show lymphopenia. Okay, amazing. With a sodium level of 130. So this is hyponatremia. I'm sure that you would have diagnosed this by now. Hyponatremia is also going on, and chest involvement is quite severe. Mild acute AKI and slightly deranged liver function test. You are concerned that he may have Legionnaire's disease. Oh, so they have already mentioned Legionnaire's disease over here. And there I was trying to look and find out whether this could fit in the criteria for Legionnaire's disease. Now you see what happens over here. I just wasted like 40 seconds, but you don't have the luxury of 40 seconds in your exam. So if you would have gone, trust me guys, I did not know that it is written over here. So which one of the following tests would be the first choice to confirm this diagnosis? If you would have read this earlier, it would have saved quite a lot of time, because just the last word itself, they have given the diagnosis. So no points for guessing it, right? Because even if I diagnose it as Legionnaire's disease, Legionella pneumophila, no points for guessing that. But they are trying to ask something else. The first choice to confirm Legionnaire's is always and always a rapid urine antigen test. And why do we do that? And why don't we do a blood culture or a sputum culture? Because first of all, culture takes a lot of time. Okay. And the urine test, I use the word rapid. This test is rapid. And the beauty of this rapid urine antigen test of Legionella is about 90% sensitivity of this test. Okay. So you should be almost 90% sure that if the test is coming positive, your patient is having Legionella, right? So No points for guessing Legionnaires in this, but this is what happens in your real exam, guys. You will read a very long stem and your quite a lot of time has been wasted over there, and then you find the diagnosis written at the end. That becomes very disappointing. So instead of that, sometimes try and look at from here the other way around, because at the end of the day, you not only have to diagnose the patient over here, but you also have to answer the question correctly, right? Let's try and see what are they saying about Legionnaire's disease. Legionella pneumophila is the one causing with the pneumonia and often extrapulmonary manifestations. Yes, we have so many extrapulmonary manifestations. We have an AKI, we have liver involvement, right? Definitely we have quite a lot of pulmonary involvement going on over here. Crackles as well as wheezes there. O2 sats are reduced. Okay. Now, the two things that I want you to remember in your that pointer that I was saying, right? If we are talking of Legionella, the first thing will be a travel history. Do not miss on a travel history, guys. Not only just for your exams, but always try to take a travel history. Nowadays, it has become even more so relevant. Please take a travel history of your patient. Okay. If the patient has recently traveled, that means that the patient has been exposed to something that he's not usually acquainted to. So what could that be? Whenever you travel, you stay in hotels. And whenever you stay in hotels, you use someone else's air conditioning system. Someone else's air conditioning system generates aerosol. And when aerosol is generated from a water source, you develop Legionnaires. Okay, that's the story behind travel history. The second thing is hyponatremia. Guys, hyponatremia in a patient with primary lung involvement is very classic for Legionnaires. Okay, I cannot stress it more than this, but it's pretty classic for Legionnaires. You don't have to even think otherwise. So a trip to Rome and hyponatremic patient with low oxygen saturations, go ahead with Legionnaires. How to rapidly diagnose Legionnaires? You would do a urine antigen test. Definitely blood culture would do, but it takes quite a lot of time. Okay. All right. So we have reached the end of the evening, but there is something that I want to discuss with you, and that is the anti-tubercular drugs that we were talking of today. Previously, I spoke about certain drugs, but I think I should tell you about the major side effects of these drugs, right? Because this has been tested more than 1 million times all over the world. Because why do you think they always test on side effects of anti-tubercular treatment? Have you thought about it? Think, why are they so focused on this particular question, and why are they not asking some other drug treatment? Because the duration of treatment of antibiotics that you are administering to a tubercular patient, first of all, the immunity is quite low. The patient is already suffering from quite an extensive disease, right? And on top of that, you will give the patient a treatment for 6 months, right, guys? Which is the other disease in which you would want to treat the patient for such a long duration of time? Okay, I'll repeat my question. Which is the other disease, infectious disease, where you would want to treat your patient for such a long time, guys? Please write in the comments box, and the answer to this question I'll give you in the next class. But I'll give you a hint. The treatment is via doxycycline, okay, usually. And the treatment goes prolonged for 6 months, maybe 1 year sometimes, okay? Coming back to the topic of anti-tubercular treatment, side effect, most common side effect of rifampicin is hepatitis, right? Liver injury. The thing that rifampicin stands out from all the other drugs is it causes your secretions to become orange. If you have a look at it once, you are never going to forget it. The color orange of urine, of tears, of saliva is very classic for rifampicin. So hepatitis as well as orange discoloration of secretions. Okay. Another beautiful thing about rifampicin is it is rifampicin. Okay, if you could get my point, rifampicin is a very potent enzyme inducer. Please remember that. What enzyme inducer? Liver enzyme inducer, right? So you will always encounter this, a patient on rifampicin along with something else. That drug is not working because why? Because of rifampicin, it is inducing the metabolism of that drug. Okay, so please remember it's a very potent enzyme inducer. Coming to the second drug of the evening, it's isoniazid. Very notorious drug, but very useful and wonderful drug. Okay, now, okay, so you've answered leprosy treated with dapsone. Okay, very correct, guys. Leprosy is one disease where you would, the parallel brother of tuberculosis is leprosy, which requires a very prolonged treatment with dapsone. That is absolutely correct, guys. And not only dapsone, there are other treatment, other drugs that we use in that. So that is very correct. Okay. But I would still want, if you could think of something wherein you would want to give a very potent drug like doxycycline for very long periods. Okay. Extending 4 to 6 weeks, more than that. Okay, so coming back, isoniazid, the most, okay, what is the side effect of isoniazid, guys? Type in the comment box. I'm waiting. I'll move on to the other one by that time. The third one is pyrazinamide. Please tell me what is the most significant side effect of isoniazid. Please. I want to know whether you have understood anything from the previous lecture or not, because that not only gives me happiness, but that also makes my work a little bit worthwhile and makes our team so much more happier when you guys are involved with us. That really makes us so happy. So coming to pyrazinamide, the first thing is hepatitis. Okay, don't forget that pretty much all of the antitubercular drugs cause hepatitis. Okay, this is the first thing. The second thing is joint pains. And this joint pain is even more so severe in a patient who is already a patient of gout. If your patient happens to be of previously diagnosed or previously comorbid with gout, he is going to suffer from a gouty attack because of the hyperuricemia caused because of pyrazinamide. Okay, the fourth drug is ethambutol. Now, what do you think this is the side effect is? Optic neuritis. Correct? Optic neuritis is the most notorious side effect of ethambutol. That is why you not only check the visual acuity of the patient before starting treatment. Please remember, guys, you have to perform an LFT of the patient before starting antitubercular treatment, because you need to know the baseline liver values, right? Before starting patient on 4 drugs that will damage his liver, not necessarily, but yes, 4 drugs that can damage his liver, you need to have a baseline liver function test, don't you? Secondly, you want to assess what is the baseline visual acuity of my patient, right? Before giving ethambutol. So that is the first thing. The second thing is this dose needs to be adjusted with renal patients. So you have to adjust the dose, but I don't think this is very relevant for you right now. Another drug that I would want you to know, because it was mentioned in one of the options, I saw that, streptomycin. So this is notorious for causing vestibular damage. Okay, so you have answered, I can see in the comments, peripheral neuropathy, hepatitis, SLE, most hepatotoxic, neurotoxicity. Very correct, guys. Very correct. Thank you so much. So let me finish streptomycin quickly. So there are 2 things that are damaged by streptomycin. Okay. The first and the foremost is your vestibule of the ear, causing vertigo, vomiting, and other things. The second is your cochlea. Don't know if you can see here, but cochlear damage is also causes deafness. So streptomycin, high dose streptomycin should never be given in a patient wherein you do not know the baseline hearing values, right? You need to perform an audiometry before administering high dose streptomycin to a patient. Also, There are patients whose livelihoods depend on hearing, for example musicians and audio technicians, right? So you need to be aware of the occupation of the patient before prescribing an ototoxic drug like streptomycin, gentamicin, etc., right? So keep that in mind when you're prescribing these drugs. Coming back to our beloved isoniazid, this causes peripheral neuropathy, okay? And this is the most hepatotoxic out of the 4. So everybody talks of rifampicin being hepatotoxic, right? But isoniazid is the first one that we stop when we consider hepatotoxicity going on in a patient, right? So peripheral neuropathy is the most noted side effect of isoniazid. Please remember that. If you want, I'll repeat it again. And what you can do to prevent that is vitamin B6. Right? That is pyridoxine. Pyridoxine administration needs to happen concurrently with isoniazid. So please remember isoniazid along with pyridoxine. This way you will never forget the two, right? Always remember isoniazid in your head along with pyridoxine. Okay? So don't think of isoniazid separately and pyridoxine separately. Think of them clubbed in your head. Only then you'll remember the two. Okay? Okay. And apart from ethambutol, pyrazinamide needs dose adjustment in CKD patients. Very correct. In fact, most of the drugs need to be reevaluated in CKD patients on TB treatment, anti-tubercular treatment, right? So thank you for that. So this is what happens when you're involved in the series that we are conducting here. Okay, so I think we have discussed quite a lot of things over here, and that should be enough for the evening. For those of you who are our premium members, we'll soon be telling you about the premium classes that we'll be conducting later on. For those of you who haven't subscribed to our channel, please subscribe to us, right? Please hit the subscribe button, right guys? And for those of you who are not yet joining us on Telegram or elsewhere, please join us on Telegram as well, right? And what we are trying to do over here is not only acquaint you with the questions, but also to make you understand the methodology behind handling such a high value exam, right? You cannot be underprepared for such a high value exam. You need to put in your best, and we are trying to provide you with the best resources that can be available, right? So follow us on Twitter, Instagram as well. Please visit our website and look out the options, check out the options over there. But do follow us on Telegram, join us, and we will be updated about the latest updates. Thank you so much, guys. Have a wonderful evening. Keep studying hard, right? And crack medicine. Good day.